Wonderful. So once again, welcome back. I am seeing there are a lot of new doctors are also joining. So I'm going to give you the quick idea and a view of our website and our things. I myself, Dr. Munjal Pandya, and we are preparing many students globally for various exams like FMG, NEET PG, pre-PG, and all various exams for Middle East countries as well. So this is what we provide usually. We are A to Z. We have book online subscription, WhatsApp subscription, Oman Viva data flow, short package, mobile application, dedicated mock test, and lots of various subscriptions as well. So you can inquire later on. Another important thing, we just recently launched the dental program as well as homeopathy. So if you have any homeopathy friends, you can tell them. And this is our dental program we are going to launch soon by maybe next week or so. And another is homeopathy, as I told you. And I will guide you for the one of the best package what we have later on. Just to save the time, we recently renewed our license in UAE as well as an established company, medical MCQ for all, last month. And those who are new, I'm practicing hemato-oncologist and bone marrow transplant fellow for last almost 20 years now, and having quite vast experience in teaching and coaching with our excellent team here with pediatrician, internal medicine, emergency physician, dentist, homeopath, gynecologist, and support team Pallavi. And this is our all detail. And last but not the least, before I start my session, this is our YouTube channel. Those who are sincerely looking for some academic things, I strongly recommend. It is just 202 video, but we have more than 400 plus. But we just recently uploaded 202 videos, which is absolutely high yield, right? Where you're gonna get all the subjects under one roof, right? So you can subscribe this more than 6,500 already utilizing this as of now. And another important thing is we have two mobile application. One is on the Android, so if you are using Android phone, you can download application, and another is iOS or Apple, right? So you can completely surf our whole website and all videos from your mobile phone, and whole website can be accessed from mobile phone as well. So that is also compatible even with the laptop and this tablet as well. And those who are preparing, I every time I'll emphasize that they should do a mock test. Mock test. Without mock test, you're gonna get never gonna get the idea about how you, improving, or how is your preparation, what is your score, what is your marks. So you must give at least one. I prefer two mock tests per week, believe me. And you check your score. If you are not getting 80% plus in our mock test on our website, it is not good time to give the exam. Believe me, I'm giving you the general idea of last 10 years of my experience coaching, teaching to the Middle East and all other various entrance exams. So 80% then you probably have like safe zone and more comfort to get through the exam. Less than 60, 65 is not at all a good idea to go and give the exam. So that's it, and let's start. What we gonna discuss today is all high yield questions, and every day you will see in your practice, especially in your clinical practice, multiple myeloma, acute versus chronic leukemia, low platelet. Low platelet is every OPD you have low platelet. It starts from dengue to leukemia. Anemia, you can see iron deficiency, anemia of chronic disease, right? Blood loss anemia, road traffic accident, thalassemia, lots of anemias. Platelet, obviously, it's one of the biggest topic, right? So we'll see, and there are a lot of this spot diagnosis questions as well. So just be with me, and I would be happy to answer each and every queries, right, during the questions finished or at the end of the session. So don't hesitate to ask the queries. This is golden opportunity for you to ask to directly to the expert. So I would be happy and glad if you can ask me lots of questions, especially any. Don't shy to ask the questions, right? This question is silly. No question is silly. Just open up and discuss. You will learn a lot. So let's start with the first questions without wasting the time. A 23-year-old woman comes to the emergency department with increased menstrual bleeding, gum bleeding, and while she brushes her teeth and pathology on the physical examination. Physical examination is otherwise normal except pathology, and her blood workup shows hemoglobin of 12 gram percent, total count of 7,000 per cubic millimeter. That is WBC white blood cell count. Platelet is 17,000 per cubic millimeter. Her liver functions means LFT, renal functions means RFT, viral serology means HIV, HBsAg, HCV, ANA that stands for anti-nuclear antibody for autoimmune disease, which is all normal. What is the most appropriate next step in the therapy? So here the options, right? One is you gonna do bone marrow biopsy, intravenous immunoglobulin, prednisolone, antiplatelet antibody, platelet transfusion, or something else you want to do. So you think of the answer, what could be the answer of this, and we'll dissect and we'll try to differentiate all why this not. And this is tried, I posted newly here every time. So in triad, there are three things: diagnosis, investigation, and treatment, right? So here they had directly jumped on the treatment. If you can see, they are interested in therapy. So how you gonna do without diagnosis? You can jump on the treatment. So first of all, you need to keep this triad always in your mind while you are thinking of any MCQ. So first of all, you need to make out or figure out what is the diagnosis. Then your job is bit easy. Yes, please. We are already more than 20 joined now. So I would be happy if somebody can voluntarily answer these questions. We'll discuss. Yes, anybody wants to have any
Let
comment?
me
Now
start.
The
it's
the
Sir,
diagnosis ITP
diagnosis is ITP.
okay. Diagnosis is
ITP
ITP. One by one.
and
Yes, sir. So,
option
sir, so I will ask you a few questions. Diagnosis is ITP. So now tell me what is the full form of ITP first of all?
idiopathic uh,
Idiopathic. So now old word is idiopathic. Now it is almost gone. Just for your knowledge, it is
auto, autoimmune.
immune. Not autoimmune. The name itself, I stands for immune. Just for your knowledge,
Oh, sorry,
immune
sorry.
thrombocytopenic. No, it's fine. No problem. No
Purpura,
need to be sorry.
purpura,
Immune
purpura.
thrombocytopenic purpura. Okay, fine. So this is diagnosis. Now, can you tell me on what basis? I'm thinking this patient is suffering from acute leukemia, right? Let's discuss. I think this is acute leukemia. Why you think this is ITP? Now we can open up.
One thing is gum bleeding, and there
So
is a
let me do the head-to-head comparison between acute leukemia. My explanation is acute leukemia. Your is ITP. Okay. So now you tell me. You start. So we'll discuss head-to-head comparison. This is learning. Yes, tell me.
sir,
Tell me how you differentiate this from this one by one.
in ITP only platelet is low. Other thing will be
ITP
normal.
platelet count will be low. In acute leukemia, platelet count also low. So how you
Yeah,
differentiate? Acute leukemia usually present with a low platelet. That is a diagnostic point. I mean, any patients like present with low
WB,
platelet, our
Sir,
yes. So
here,
this is you
here
can
WBC is normal.
W
wonderful.
with
So here,
normal in ITP.
hemoglobin and white cell is usually low or high. Here, hemoglobin is also normal and total count is also normal. They both
Yes,
patient
sir.
can present with bleeding, gum bleeding, urine bleeding, patechi, ecchymosis. Here, bleeding is also there. So this is the beauty that only low platelet is there in ITP or immune thrombocytopenic purpura, where hemoglobin and WBC is normal, and this is called as isolated thrombocytopenia. Isolated, only low platelet, isolated, right? And if you talk about the sign and symptoms, right, here you have hepatomegaly, splenomegaly, bone pain, weight loss, right, blah blah, lot of things, a blast cell in the peripheral smear. Here absolutely normal. So simple one liner definition of ITP is only platelet count is low in CBC. Rest of the other things, whatever you can speak of and think of, all normal. Whatever you say, I will tell only one. It is normal. Liver normal, spleen normal, viral serology normal, liver function normal, ANA normal, this normal, bone marrow normal, everything normal. You understand? ITP is a diagnosis of exclusion. So now we have now reached up to right 12 hemoglobin, right? So now let me tell you the definition of anemia as well. I took a big lecture on anemia or CBC interpretation last week. So those who missed it, it's on our YouTube channel. I'll share the link again. You need to remember three words: 13, 12, and 11. 11, 12, 13. Pregnant woman, pregnant female plus pregnant less than 11 anemia. Non-pregnant female less than 12 is anemia. And male, right? less than 13 is anemia. So just remember simple word, not complicated. 11.5 and 12.5 and 30, complicated. Less than 11, this is from book only, it's not from my side. So less than 11, pregnant female, less than 12, non-pregnant female, 13, male, anemia. So we need to have clear-cut idea, right? So this is 12, normal. WBC 4,000 to 10,000, 11,000, normal. This supposed to be 150,000, means 1.5 lakhs to 4.5 lakhs. It is normal, right? So instead of 150, it is just 17. Rest of the whole thing is normal. So this is ITP. Anybody wants to comment on this, what I explained you for the ITP diagnosis? Everybody's, I think, agreed with this, right? Now we make a diagnosis. So out of three triad, we solved one triad, right? One arm of the triad is solved. So now this is ITP, firearm, right? Investigation. Can anyone tell me how you do the investigation of ITP? What are the investigation points of the ITP? And then we'll jump to
It's
the
a
therapy as well.
diagnostic exclusion.
Sorry.
CBC.
Yeah, so CBC we have done, na? CBC we have done. So you can tell me CBC. I can tell 20 investigation for ITP, or basically low platelet count. Low platelet. ITP is basically isolated thrombocytopenia, low platelet count. So only you will do CBC. So CBC, what you see, low platelet count. Liver function test, absolutely normal. Renal function test, absolutely normal. Right? Also viral serology, HIV, HBsAg and HCV, we call it shortly triple H, negative, right? Bone marrow biopsy, everything is normal, except only one thing, increase in the megakaryocyte. That's it, increase the max. Otherwise, all fine, right? Morphology is fine. There is no structural abnormalities. If you do the cytogenetic, it's normal. If you do the flow cytometry, normal, right? If you do something CT scan, chest, abdomen, normal. Everything is normal except low platelet. That is ITP. So the number one right sentence in the book of Oxford and book of Medicine and Davidson Harrison, ITP is a diagnosis of exclusion. That's it. So there is no other cause, only low platelet, it is ITP. If you find dengue fever and low platelet, it is not ITP, no? It is a dengue fever, then diagnosis will change. If you have malaria and low platelet, then diagnosis is malaria, not ITP, right? Malaria, normal, dengue, normal, serology, normal, MP by card or whatever you do, normal. You understand? Is it? Are you getting me? At least tell me yes or no.
Yes, sir.
Wonderful.
Yes,
So
sir.
diagnosis is done. Now investigation is done. Diagnosis of exclusion. Now you want to jump on the treatment. So what is the treatment? Now what is the appropriate next step in the therapy? Therapy means treatment. So in exam they're gonna ask you, either they ask you diagnosis, they ask you investigation, they ask you treatment. So here they ask you the treatment. So how you supposed to treat this patient of ITP? Any
By
comment?
steroids,
And
by
why?
steroids, sir.
By steroid. Okay, by steroid. So one answer is steroid. I'm saying why you don't want to treat with IV immunoglobulin. I want to give
So
IV immunoglobulin to
immunoglobulin
this
is
patient.
given when
I
there
want
is
to,
massive bleeding.
I want,
GIO,
yeah, I want,
uh, brain bleeding, we give IV
wonderful.
immunoglobulin.
Wonderful, brilliant. So I want to increase. So IVIG increases the fast, right? But just write down. This is another question in the exam. In which condition you supposed to give IVIG? So one is a less than 10,000 platelet count, very critically low. At that time, there is a risk of intracranial hemorrhage, spontaneous risk of intracranial hemorrhage, less than 10,000 count. In that case, you can give IVIG. Number one, right? This is prophylaxis basically before bleeding happens. What if bleeding happens? Then remember 2B, brain bleeding and bowel bleeding, massive intracranial hemorrhage or bowel hemorrhage, give the IVIG, right? And when there is a steroid is contraindicated steroid, right? Or very poor diabetic patient, in that case you also think of IVIG. And pregnant woman, these are the few common indications of giving IVIG. So they're gonna ask you what are the indication of IVIG, giving IVIG in ITP. So these are the indication you must remember, right? So steroid is a first line treatment. Steroid is a first line treatment, right? In the stable patient. So this is a stable patient. This is a stable patient, right? Platelet counts are more than 10,000, 10,000, right? He is not bleeding from brain or bowel. So patient is stable. Patient has a low only count, otherwise fine, everything is fine. Patient is young, fit, healthy. Otherwise, not a problem. In that case, you can start with the prednisolone, right? The dose of prednisolone for your kind knowledge in clinic is 1 milligram per kilogram per day, 1 milligram. So 60 kg male or female, you give the 60 milligram dose per day, right? You may divide 20 morning, 20 afternoon, 20 evening. That's it. Post meal, right? Empty stomach, it can cause gastritis. And everyone should know the long term side effect of prednisolone. This is not a short course. This course you give at least for 3 to 4 weeks. And once the platelet counts gets up in 3 4 weeks, then you gradually taper for 40, then 20, and then 10, and then 5, and then you can stop, right? You cannot abruptly stop the steroid. Can anyone tell me if what happens if we don't taper? What happens? We stop. Patient is on 60 milligram per day for say for example 4 weeks. 4 weeks he continuously took 60 milligram, and next day you stop. You are not tapering. Anything happens wrong? It's a practical question and important too as well, because we are tapering. No? We are on by ourselves. We are tapering, but we don't know the logic of tapering. Yes, anyone? Any idea why
To
we are not
avoid the
tapering?
side effect of
Yeah.
steroid.
Sorry.
To avoid the side effect of steroid.
No, not because of side
There,
No,
effect
there
of
should be
sudden
the
cessations
there
of
should be the
steroids,
adrenal
hypothalamus pituitary
insufficiency.
adrenal suppression.
Yeah, there
wonderful,
should be
brilliant,
adrenal
brilliant,
insufficiency.
wonderful. Yes, so this will develop the acute adrenal insufficiency, right? And patient may go into the shock. So go and read, right? Addison's disease, Addison's, that is adrenal insufficiency, right? Cushing syndrome is hypercortisolism. Addison's disease is hypocortisolism, right? So sudden abrupt, right? You are giving exogenous steroid, and now all of the sudden, right? The adrenal is suppressed, and you stopped it. It takes time to generate. So it's an acute adrenal crisis. That is the reason. Obviously, long-term side effect like osteoporosis, hypertension, fluctuation in the sugar, worsening of the peptic ulcer, Cushingoid phases, osteoporosis, lots of side effects of steroid, long-term, not the short-term. But that is also another second. But biggest things why we are tapering is because of adrenal insufficiency, right? So that's it. So now what we discuss lots of things. What is the diagnosis? We solved it very clear cut. Treatment we do it. We need to know only two major treatment. One treatment is a steroid, and when we supposed to use the IVIG, I already told you. At this stable patient, usually you don't need, right, the excellent classical case. You don't need to do a bone marrow biopsies until and unless you suspect some atypical things. See some atypical cells in peripheral smear, blast-like cell scenes. If somebody says blast-like cell scenes, in that case, definitely you need to do a bone marrow to rule out the acute leukemia, right? But nothing is there in this scenario, so we are not going to go for bone marrow biopsy at this point of time. So now let's dissect the all other options, right? As we are, I mean, routinely doing it. So this is final answer. The young woman with isolated severe thrombocytopenia of 17,000 with mucocutaneous bleeding like menorrhagia, gum bleeding, pathology with normal hemoglobin, white cell, liver, renal, ANA, viral serology. Classically, it's a immune, not idiopathic, immune thrombocytopenic purpura. First line treatment is corticosteroid or steroid. Options by options breakdown. So why other options are not the answer? Somebody saying, sir, I want to do the bone marrow. Why you don't need to do now? No need in a young patient with typical ITP and normal other counts. If WBC is high, if the or if the hemoglobin is low, if pancytopenia is there, absolutely mandatory. And when there is a pancytopenia, it is not ITP. ITP is just isolated thrombocytopenia, not the pancytopenia. Hemoglobin white cell is normal always. So it is not required in a classical case. IVIG is used in especially in life-threatening condition, as I told you, pregnancy or when you want to rise very rapidly or fastly. Prednisolone or steroid is the best answer. First line therapy in all patients until proved otherwise or unless contraindicated. Anti-platelet antibody, right? Diagnostic tests are not required and do not guide therapy as well, irrespective whether anti-platelet antibody is present or absent. You gonna give the steroid. So it's not practically used, and I never did it in my last 20 years. Without that, patients are getting better with the steroid. It can be done, but there is no, I mean, sensitivity, specificity is not good, and it could be a many, many a times false positive as well. platelet transfusion is not required, rather it is contraindicated in non-life threatening bleeding, right? So when there is a life threatening bleeding, at that time you need to give the platelet transfusion. So one other question comes in my mind right now. What are the contraindication of platelet transfusion? Where you are not, so your platelet count is less than 20,000, right? Patient is bleeding, patient is bleeding, but platelet transfusion is contraindicated. Condition 1, 2, 3, 4, 5. Yes, tell me. Open for all.
Antiplatelets antibodies.
Sorry. I want to know the condition,
Antiplatelet
the
antibodies.
diagnosis. That is mechanism. I'm trying say number one indication by me is ITP. ITP, platelet platelet transfusion is contraindicated. Only indicated in one condition in ITP, life-threatening bleeding, life-threatening bowel and brain, BB, bowel and brain, life-threatening bleeding. They are clear-cut mentioned, reserved only for life-threatening bleeding as per the guideline. So gum bleeding is not life-threatening bleeding, and that is why we are not giving here, right, platelet transfusion in this patient, or right, or we are not giving the IVIG. IVIG is like is very costly drug, just for your knowledge, like probably 1 lakh rupees, right, or 2 lakhs rupees, which is not very easy to spend by Indian people, right? And it is not indicated anyway. So one condition is ITP. Anybody wants to comment on this? What are the contraindication? It's a basic question. You're supposed to know when you cannot
TTP.
give the platelet. TTP, wonderful, brilliant. TTP, thrombotic thrombocytopenic purpura, right? Another is a right? Heparin induced thrombocytopenia. Third is hemolytic uremic syndrome. These all are the condition where the platelet is low. You go and read it. I have one questions for this. This will solve in next couple next half an hour. One question is with that. So these are the condition which worsens the condition, which worsens, right? The condition, right? So if you give, the platelet transfusion in this TTP, thrombotic, more thrombosis will be there, more thrombosis, more platelet aggregation, right? You are worsening the clot, right? Already patient is in clot. You are adding platelet, you are making more clotting system activating. So these are the condition where it is contraindicated, right? So just keep in mind while if they ask you in the exam. So this is all clear from my side. So last but not the least, what's the explanation? CBC showed only low platelet count, isolated thrombocytopenia with normal HB and WBC. Bone marrow shows increased number of max. I already told you with a normal morphology. It is absolutely important. Somebody is asking, sir, why? What if it is abnormal morphology? Then think of MDS, myelodysplastic syndrome. If it is abnormal, then think of MDS, myelodysplastic syndrome. It is again a bone marrow disorder, right? So increase max with normal morphology of megakaryocyte. So this is a stem cell. Stem cell eventually become a megakaryocyte, and megakaryocyte, the platelet formation. We'll see that tree in next couple of questions. So you need to know, right? So megakaryocyte is mother of platelet. It's a mother of platelet. So megakaryocyte is mother and platelet is son, right? So what happens when you have low platelet? Megakaryocyte increases in the bone marrow, which is increases in the bone marrow. But if you see it, morphology is normal, so not abnormal. Bilobated, trilobated, hypolobated. This is all abnormal. We'll sometimes see in MDS, right? And one of the treatment of ITP is splenectomy. So can anyone tell me what vaccine we supposed to give before splenectomy? ITP treatment, one is steroid is the first line treatment, right? As I told you, steroid. In emergency, when you want to increase very fast, IVIG is one of the most important options in emergency. After steroid, if does not work, then there is a thrombopoietin, TPO is available, like EPO, erythropoietin, right? So whenever renal failure, anemia of chronic disease, we give erythropoietin subcutaneously to our patient, especially renal failure patient, where we give subcutaneously erythropoietin. Why erythropoietin we are giving? It stimulates the erythropoiesis and try to increase the RBC and hemoglobin. That is why we are giving it. Likewise, right, there is a on this is a receptor on TPO receptor on the platelet, right? Receptor thrombopoietin. So this thrombopoietin helps the megakaryocyte to make a new platelets. So TPO is drug. So one important drug we are using it steroid in our practice. Second is a just for a kind knowledge, L thrombopag is another drug, and another is romipostym. These are the two drug available. Romipostyn is not available orally. This is available orally. PO available. This is sub-Q injection, but it is available. And third options for the drug is various immunosuppressant agent, right? Like cyclosporine, cyclophosphamide, mycophenolate mofetil, azathioprine, and there is a long list of this immunosuppressant drug. So these are the standard cascade of using, I mean, treating the ITP patients globally as per the guideline. So steroid is the first line. If it is failed, then TPO. If it is failed, then third immunosuppressant agent you can use for this patient, right? So and everything fails, there is a one treatment options is a splenectomy, because all the destructions of the platelet happens in the splenectomy. So if you remove the spleen, platelet count will increase. So can anyone tell me what vaccine or does any vaccines required before splenectomy or not required? If required, then what are the names and why?
Pneumococcal, meningococcal, and Hep B.
Wonderful, brilliant. So splenectomy, when you are going to do, you need to do meningococcal, pneumococcal, pneumovac 23, pneumococcal, meningococcal, and Haemophilus influenza type B. Again, question: why you want to give sir this vaccine before splenectomy? Because spleen is a lymphoid organ. It is the immunity of our body, policeman of our body. When you remove the spleen, you have increased the risk of this opportunistic infections. So, in emergency, if you have emergency surgery like road traffic accident and spleen is ruptured badly, heavily and massively bleeding and need immediate laparotomy, you do the splenectomy, and after 2 to 3 weeks you administer the vaccine. If the patient has a no emergency, planned a splenectomy in ITP patient, okay, fine, we'll do it after 4 weeks. Splenectomy, give all three vaccines now. It will fight against this capsulated organism, pneumococcal, meningococcal, and Hib. Is all clear to everyone? Yes or no? Are you getting me what I'm trying to explain?
Yes, sir.
Yeah.
Yes, sir.
Wonderful,
Yes, it's
brilliant.
clear.
Wonderful, brilliant. So now this is last slide for this, ma'am, right? So this is all low platelet. So if you have low platelet, it's a very important slide, I guess. I'll try to gather it for you guys. So if you have low platelet and kidney problem, if you have low platelet and increased creatinine, think of HUS, hemolytic uremic syndrome. If you have low platelet plus patient is neurologically very much altered, think of TTP, thrombotic, because thrombosis in the brain, thrombotic thrombosis in the brain. DIC, disseminated intravascular coagulation. You have low platelet count, also you have some kind of clot, right? DIC is both disseminated intravascular coagulation and bleeding, both things goes together, right? Think of DIC. ITP, as I told you, only isolated low platelet. Bernard-Collier syndrome and Glanzmann. So Bernard-Collier is adhesion problem. These both are the platelet functions disorder. It is not a number disorder, it is function disorder. This year, all four are the platelet number disorder. So this is called as a quantitative problem. Quantity is how much? 1.5 lakhs to 4.5 lakhs is quantity. So anything less than 1.5, you can see HUS, TTP, DIC. Here the platelet count is more than 200,000. Platelet are absolutely normal, but still they are bleeding. Why? Because it's not a number problem, it's a function problem. So Bernard-Collier and Glanzmann's thrombasthenia. This is the name of the complete disease. Here the adhesion problem. So this is a endovascular, this is vessel, this is a endothelium, right? Here the von Willebrand factor. Von Willebrand factor, we have a questions. So what van Willebrand do? It helps the platelets to attach to the endothelium at the site of bleeding, right? So when the adhesion does not happen, it is Bernard-Collier adhesion problem, right? And this will and platelet gets aggravated. All platelet gets aggravated and form the clump. So when platelet does not get activated or aggregated, it is Glanzmann. So it's a two different thing. One is adhesion problem, another is aggregation problem. So let's move to the next. Yeah, that's all from my side for ITP and all related basic different logistics. Any questions to this in the audience?
Sir, at what level of platelet ITP is treatable? Some people's having ITP for a long time, up to 100 or 99 platelets. Is they are treatable?
Platelet with ITP can be treatable at any stage. We had one patient in my OPD. Platelet count is zero, just for your knowledge, zero platelet count. Absolutely zero. I did a bone marrow because it was zero. Now I need to know what is the real reason, whether it is ITP or not. It is turned to be ITP because increase the megakaryocyte in the bone marrow, as I told you. Rest of the all morphology is normal, right? And it is treated with the steroid, and fortunately, patient is fine. So any number, low number, any age, ITP can be treated. Are you getting my point, or you got your answer or not?
Sir, I want to ask some people having ITP for many years and
Yes, yes.
there is no
Important
bleeding.
question.
There is no
Wonderful.
bleeding. There is no
I'll tell you
bleeding,
that
no
one.
complication. So
I
what
got
will
your
do with them?
questions. Right. I have a slide for you which will clarify all your answers. It is an important, very, very important question. And this is the answer for your things. Right. So this is mainly applicable to chronic ITP. Those have ITP. So what is acute and chronic? Less than 3 months of low platelet acute. Anything more than 3 months. Many a guideline says 6 months. So I can say more than 6 months. Any low platelet more than 6 months in ITP is a chronic ITP. This is acute ITP. This is chronic ITP. So I'm talking about chronic ITP. No bleeding and platelet count is 30,000 plus, no treatment required as per the guideline. If patient has a bleeding, any kind of bleeding, even though 30,000 platelet, like our patient has a 17,000 patient and bleeding, gum bleeding, this bleeding, petechia, this is symptomatic patient. So where you need a steroid or glucocorticoid or steroid. Severe bleeding, bowel and blood, right? And brain. GI means bowel and brain. Less than 10,000 count, give the IVIG, right? And there are a lot of options, as I told you. So answer of your question is more than 30,000 of platelet, no bleeding, patient asymptomatic, chronic ITP, no treatment as per guideline. Monitor them. Are you getting me what I'm trying to explain?
Perfect. Perfect, sir.
Wonderful. So this is a guideline. So this is all complete clear cut slides, right? Just to make cut short. I mean, I deleted this, but it's a good question. Very good questions because this is there are a lot of patients moving around in the society who have 50,000, 60,000, 70,000. They never bleed. Even they don't know I have low platelet or something like that, right? Because they are asymptomatic, they are fine. But when you check for something else, then when you have fever or something else, going for body checkup for US immigration, then, oh, your platelet is 70,000. What to do? Nothing to do. Is that clear?
Yes, sir.
Wonderful. Any other questions in the audience, or I'll switch to the next question? So I think nobody will do
Sir,
now
hello.
mistakes.
Uh,
Yes. So,
Sir, I have
yes,
one question. Can you
yes,
just
please ask me,
explain
madam.
what is the mechanism of action, like how steroids help with ITP? If you can just clarify it in a
Wonderful.
summary.
Wonderful. 1 minute. Yes, wonderful. So this is a platelet, right? Here the receptors on the platelet. So ITP is immune mediated. So when there is a immune mediated, some kind of abnormal antibodies will develop in the body. How come this abnormal everybody antibody develop? Probably after viral infection, some drug. Even we see in our unit, chemotherapy unit, after post chemo, right? Because of this, abnormal antibody will develop, increases in the plasma, and this antibody, right, will attach with the antigen on the receptor. Usually the receptor is GP23B. GP23B, this is receptor on the platelet. So this antibody will bind to the platelet, and what it does, it do the fast destructions of the platelet in the spleen, right? So destruction site is the spleen, right? So what is the primary goal? You have to reduce this antibody. Are you getting me? Yes or no? If you remove by any chance this
Yes, sir.
antibody from the plasma, it will not destruct the platelet and platelet count will be increased. So this antibody will be reduced by the steroid. Steroid reduces this antibody. whatever the drug options are there, most of them it reduces by this, right? And all immunosuppressant agent will reduced, right? This antibody. So this is, and this is how, this is the mechanism, right, of the platelet destruction. So our main goal is to not increase the platelet. Our main goal is to reduce the antibody, right? Reduce the antibody. So this is one action of steroid. And how the IVIG act, again important. So this is platelet, right? This is receptor. So in spite of attaching antibody here on the platelet to destruct, IV immunoglobulin will attach and protect the platelet. So now there is a no free space for antibody to attach on platelet, because already the IV immunoglobulin is attached here. Now no receptor is free for the breakdown. Are you getting me? Yes or no?
Yes,
Are
sir.
you getting me
This
what I'm
makes,
trying to
yes,
explain? Right?
yes,
So this is the role
yes.
of IV immunoglobulin, IVIG immunoglobulin, right? So this is again antibody, na? Five types of antibody which is made by the plasma cell made from B cell, B lymphocyte, plasma cell, and it makes five antibody immunoglobulin, GAMDE, right? If I'm not wrong, right? So this immunoglobulin, IG is immunoglobulin. So this is formed by this. So this immunoglobulin antibody will attach here on the surface of platelet, and it prevents the abnormal antibody to attack on the platelet, because there is no space to attach at the platelet surface. I'm just trying to make it very simple and clear cut for you rather than more complicated. Are you getting me or not happy with the
Yes,
answer?
sir. Yes, yes, sir. It makes all sense now.
Wonderful, brilliant,
Yes.
wonderful. So let's jump to
Yeah.
the next questions. Probably I think it's a very important and interesting whole day debate can go on this. Now, second questions. 16-year-old boy present to his GP, general practitioner, complaining of nosebleed and bleed after brushing his teeth. He is unsure how long this has been occurring, but decided to seek advice after having to continuously excuses himself from lessons. On examination, you notice that he has some skin bruise. A blood test shows prolonged bleeding time and activated partial thromboplastin time. While platelet counts and prothrombin times are all normal, the most likely diagnosis is von Willebrand disease, liver disease, disseminated intravascular coagulation, congenital fibrinogenemia, and Glanzmann's thrombasthenia. So think over it for 10-15 seconds. I need a reasoning. So here lots of questions, maybe 10-20 question in this question will solve, right? So what is the diagnosis? How did you diagnose? What is the treatment? Right? Why this? Why not B, C, D, E? Why A? Why B? Why C? Blah blah. Hundreds of questions we have to discuss in this question. So first we need an answer, then we can do something. Again, as I told you, my triad. So without triad, I mean, how we supposed to go to the? So first, our job in triad is diagnosis. Second, remember this triad. I love this. I am doing every day in my OPD and IPD. So without diagnosis, now they are asking the diagnosis. In ITP, they are asking the treatment. Without diagnosis, now they are asking diagnosis. Once we make up the diagnosis, we'll jump on the investigation, how we supposed to diagnose, and then we'll jump, because they can ask you any question in exam. They will not ask you the way I teach, right? They will ask any question. Now this is the diagnosis. What is the treatment? Yes, please. So we are trying to catch up everything. Yes, everyone, anyone.
One will brand disease.
Option A.
Okay, fine. Let's other to comment. We have a facility of chat box. So if you shy to answer openly, answer your things in the chat bot. Chat box, we have it chat box. A, B, C, D, E, whatever you feel. Yes, Dr. Sudesh, you are in the class as well, I think. So what's your comment, Sudesh? Do you have any comment? Yes, any comment? Shilpa Kevi, Dr. Rajesh Radhan. Is it very complicated questions or so?
Small will brand disease. Option A.
Yes, Piyush. Yes, Piyush. What's your answer?
Option A. One will brand disease.
Wonderful, brilliant. So now I'm trying to understand why it is a von Willebrand disease. Why not B? Why not C? Why not D? Why not E? Why von Willebrand disease? How you
Sir,
differ
it,
from
Uh,
it
each
could
other?
be E. Sir, it could be E.
Wonderful, brilliant. So it could be E means Glanzmann's thrombasthenia. One answer
in
is
the
von Willebrand disease. So von Willebrand disease and Glanzmann's thrombasthenia. Let's discuss head to head just to get a more clarity. Yes. Yes, Piyush, please tell me why it is von Willebrand disease. Dr. Rabia is saying it is Glanzmann's thrombasthenia. Huh?
plasmal thrombocythemia is a platelet function disorder. So generally, it is bleeding time is prolonged and uh, activate APTT time is normal. In this case,
Wonderful,
both bleeding time and APTT is prolonged. Apart from
wonderful. So
other
you
option,
think bleeding time?
liver disease, both PT, APTT are increased. DIC also
Wonderful,
bleeding time increase, PT increase, APTT increase.
wonderful, wonderful.
In
You are absolutely going well. Right. So let me first. What is abnormal here? We need to know. So is when you are solving anything, you need to know, right? So what is the problem? Increased bleeding time. They are saying prolonged bleeding time means increased bleeding time. Increase APTT, activated partial thromboplastin time. In CBC, platelet counts are normal and prothrombin times is also normal. So PT is also normal. So now let's go one by one. In liver disease, number one, there is a history of alcohol, which is not there. 16 years of age, she will not develop the cirrhosis. This is all reasoning why you need to know. Number two, while there is a liver disease, there must be some kind of hepatitis B or C, which is not here. Right. Third thing is PT, APTT will increase, not just the APTT, and PT increase faster than APTT. So PT first, which is normal here, which is normal here. So that is a less likely cause of liver disease, right? DIC, right? Platelet is also reduced. PT and APTT also increase. So here contradictory. PT is absolutely normal, platelet count is normal, right? Here in DIC, platelet should be low and PT should be high, which is normal. So DIC is gone. Congenital afibrinogenemia means absent. From birth, fibrinogen is absent, right? Here also you can increase PT and APTT both with severely low fibrinogen, which is not mentioned here. So it is gone. And in Glanzmann's thrombasthenia, it is a platelet functions disorder. Here the bleeding time could be increased, but never increase in the APTT, never increase in APTT because it has nothing to do with the platelet factor. So far clear? Yes or no? Anybody has any objections, comment? It is highly welcomed.
Yes, sir, clear now. I'm
Wonderful,
just saying
wonderful.
because of the bleeding time.
Fair enough, fair enough. It's a learning, no worries, nothing to worry. Now let's dissect more, right? Let's dissect. So let me first remind you what is the answer is von Willebrand disease. So what is the functions of von Willebrand, right? People read about one way, but always even I was like in study, it was like boring for me. What is von Willebrand and all blah blah, right? So, and anyway, the incidence is very less, right? So, we are not seeing lots of patients of von Willebrand, though it is one of the most commonest bleeding disorder, probably underdiagnosed or undiagnosed, right? So, here the von Willebrand diseases happen because of von Willebrand factor. So, to clot the blood, there should be a platelet, there should be a factor, there should be a von Willebrand factor, there should be a fibrinogen, and lot more, and calcium, and lot of things, but these are the major component to clot the blood. So if anything is missing, this is beauty created by God. If you have low platelet ITP bleeding, if you have hemophilia bleeding, if you have von Willebrand disease bleeding, if you have low fibrinogen bleeding, if you have low calcium bleeding, you understand? So this is like if you missing anything, the blood clot will not happen. Blood clot will not happen. Clot will not happen. Everything is required in a perfect chemistry to clot the blood. And one of them is von Willebrand factor. So, von Willebrand factor has a two major functions in our body, right? One function is on platelet. I already told you, right? Von Willebrand factor in the blood, it helps the platelet to adhere with the endothelial cell at the site of bleeding. So, what happens when the von Willebrand factor is absent? platelet adhesion to the endothelium is hampered. So patients is bleeding and bleeding time is increased. Bleeding time. We don't need to mug up. We need to understand why bleeding time. So if you do a bleeding time test on the forearm of the patient, right, the bleeding or oozing time would be more. Why? Because 1 millibrand factor is absent and 1 millibrand is absent. That is why platelet are not plugging the good clots at the site of bleeding. And another thing is it is a carrier of factor 8. Carrier of factor 8. It carries the factor 8. 1 millibrand factor, right? 1 millibrand factor carries factor 8. Carries factor 8. So if it is absent, it will not carry, it will not effective clot, and factor 8 is monitored by the PTT, right? Intrinsic factor pathway, extrinsic pathway, common pathway. I'll teach you sometime. So factor 8 is in the intrinsic pathway and it is monitored by APTT, and that is why APTT is high. It is nothing to do with this, and that is why the 1 millibrand ants. So we didn't know, we never thought of, oh, this is the function of 1 millibrand. So now this is functions platelet and factor, and because of platelet, right, dysfunction, BT bleeding time increase, and because of factor 8 is not carried well, it will not make a clot. That is why the factor 8 is deficient or PTT is increased, right? That is why. So we cannot measure directly platelet factor 8, so we do the indirect test, right, which gives us idea. So this is what the thing is. Is that clear to everyone? Yes or no? You need to understand what is the 1 millibrand factor functions. So I told you the functions, right? So main functions of 1 millibrand is platelet adhesion. I already told you platelet adhesion, right? Right? To the platelet adhesion to the subendothelial collagen. Platelet aggregation is also hampered, right? It is a carrier of factor 8 and carrier and stabilizer of factor 8, right? And that is why factor 8 is right. So this is main function is carrier of factor 8, and what it does, protect the factor 8 from degradation, right? So if the 1 millibrand is not there, the degradation of factor 8 is fast. Degradation is fast and it reduces in the plasma, and that is why the bleeding happens, right? And it helps in forming the platelet plug. So in absence of 1 millibrand factor, platelet plug will not happen. But if you don't remember all this, remember simple adhesion, aggregation, and carrier of factor 8. So bleeding time and APTT will increase, right? That's it. So 1 millibrand factor, glue plus carrier. What is glue? Platelet sticks to the vessel wall. It's called glue or adhesive. And carrier, it carries factor 8, right? So, and that is why you see all the things. So what exactly happens in 1 millibrand disease, which is like deficiency of factor, deficiency of 1 millibrand factor. When it is deficiency, it is known as 1 millibrand disease, right? So bleeding time increase. Now you get to know why increase. PTT increase because of factor 8 is low, right? PT is normal, platelet is normal. In DIC, platelet is low, right? In liver disease, it is low, right? So these are the thing is, and what is the treatment? So can anyone tell me how many types of 1 millibrand disease is there? Is there any classification globally, like diabetes as classification, type 1 diabetes, type 2 diabetes, gestational diabetes, mellitus, blah blah, right? So it's a classification of diabetes. So is there any classification or type or subtype of 1 millibrand? Anyone? These common questions asked in the exam, believe me. Anyway, I'll tell you. There are the three types of 1 millibrand disease. Three types of 1 millibrand disease, right? Type 1, type 2, type 3. Just to easy remember, it is very complicated in the book, but I make it. Here the quantitative problem. Here this is also quantitative problem. But here the quantity is less. Here the quantity is absolutely absent. No 1 millibrand factor. Here 1 millibrand factor is present, but it is in the low than normal range. So both are 1 and 3 are the right. It is a quantitative problem. Quantity number is less, and 2 is defective. This is qualitative problem. Quality. 1 millibrand factor is there in a normal, like platelet functions disorder, platelet numbers disorder. So here the 1 millibrand functions disorder, 1 millibrand numbers disorder. So 1 and 3 is a number disorder where the number is low. Here low, here absolutely absent. This is worst one. This is worst one. one of the worst is there is no absolutely no one Willebrand factor at all. So there is no scope of clotting the blood. Patient is bleeding, 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 and he die eventually if not treated well. Right? So he is a quantitative problem. This is qualitative problem. This is a mild problem because one Willebrand factor is there, but it is little low. This is moderate. This is the worst one. Let me tell you, fortunately, with grace of God, 95% cases are mild. This is 2 to 5%, and this is less than 1%. So thank God, this is severe one. Incidence prevalence is very low. It is not written here, but I'm giving you the statistic. In all three bleeding time increase. In all three, APTT will increase, right? One Willebrand factor antigen, obviously, here low, here very low. This is quantitative problem. Why it is normal here? It is qualitative problem. It is normal, but not functioning well. It is quality, right? Maybe low, but more of normal, right? And that's it. And treatment is very important for this DDAVP, that is also known as a desmopressin. Desmopressin. So DDAVP is desmopressin is available, which is usually used for the type 1. 2 and 3 are more severe. So here you need a one Willebrand factor concentrate only. Word is only, because one Willebrand factor is there, but whatever is there, you have army, but there is no machine gun. Useless army. Army. So here army with no machine gun. One Willebrand factor is there but not working well. So you need just one Willebrand factor concentrate, and here, right, you need both things, one Willebrand and factor 8 carrier as well as factor as well. So that's it. This is simplified treatment of one Willebrand disease as well. So now we get to know about one Willebrand disease is what, the mechanism is what, function is what are the types, what are the treatment, what are the severity and quantitative versus qualitative problem. Right. So last one line. If you does not remember anything, I have every time tips and tricks for you. Type 1, less one Willebrand. Type 2, wrong, qualitative. It is there but wrong. And type 3, no, not at all. No one Willebrand. Here the less. Right? It is there but less. Here absolutely absent. So it is a quantitative, qualitative. It is normal but not working well. Is that clear to everyone? Yes or no? Any questions to the audience? Any questions to the audience? Yes or no? At least tell me yes or no.
All clear.
Wonderful. I am speaking aggressively for 1 hour. You at least tell me yes or no. That's fine.
Sorry, sir.
No
Thank you.
problem. That's fine. No problem. That's fine. I'm energetic man. So now final slide for one Willebrand disease. Platelet normal, PT normal, bleeding time is increased. Platelets are not adhering to the wall, and it is a carrier of 8. So 8 gets destroyed fast. APTT increase. For you, Dr. Rabia, platelet count is normal, bleeding time only increase. PT and APTT is normal, absolutely. Here in our scenario, APTT is increase, bleeding time is increase, and that is why it is not Glanzmann. Are you getting me? And hemophilia.
Yeah,
So
sir.
hemophilia is a problem of factor 8 primarily, and when there is a factor 8, right, APTT will increase, platelet, bleeding time, this is normal. So this is absolutely clear cut graph which shows that how you differentiate one from another. Any doubt? Any doubt?
No, sir. Everything is clear.
Wonderful, brilliant. I got a brilliant audience. Next questions. Anybody has any questions? I'll stop for 10 more seconds. Any random questions? Wonderful. No questions means all clear. Patient who has hip fracture repair develops a sudden onset of breathlessness, short of breath, pulse is 110 per minute, BP is 120 over 74. The chest is clear for the to the auscultation. Chest X-ray is normal. EKG shows sinus tachycardia. ABG shows pH of 7.48, PCO2 28, PO2 75. What is the next best step in the management? Apixaban. Second is VQ scan. Third is CT angiogram. fourth is D dimer, fifth is lower extremity Doppler you want to do, and intravenous heparin. Forget about right side, but first five options: Apixaban, VQ scan, CT angio, D dimer, lower limb venous Doppler study, and intravenous heparin. Again, the triad comes in the picture. So somebody learns this triad. I created this triad. I love this triad. I do it in my practice every day. Every patient, I ask three questions to myself. Dr. Munjal Pandya, what is diagnosis? What is investigation? How you supposed to treat? My 99% job is easy. You have to ask the same questions. Now they are asking the next best step in the management. So this is little tricky. This is also very important for you to know, right? Management includes the investigations. It is a part of management, right? Management includes the initial treatment. And management includes the emergency treatment. Management includes the what is the best investigation of the choice. So you need to decide, I mean, what exactly they wants to ask in the exam, right? So if you go on the investigation, answer will change. If you go on the treatment like apixaban and heparin, answer will change. And you have the liberty to select only one answer. You can't select the multiple answer in the exam. So it's important for you to know what is important now, right? Whether investigation is important or treatment. And they have not given the diagnosis. So we have three problem. We don't know the diagnosis. What we supposed to answer in this question? Which is the best investigation from option or which is the best treatment amongst the options? Again, a dilemma. So we need to figure it out. Yes, anyone. ICU people can comfortably answer this usually.
So you scan.
Which you scan. Okay, fine. So let me write your
Yes, sir.
answer, sir. Piyush, sir. You answer VQ scan. Okay, fine. Let's see what other experts are saying. Then here I write down name. I'll forget. 30 people are in house. Dr. Piyush, sir. Okay, fine. Fair enough. Any other answer from the audience?
The angiogram, sir.
CT angiogram.
Okay. Okay. So another answer in audience is CT angiogram. Means one is wrong. Either VQ scan or CT angiogram. Third answer,
A, sir.
nobody wants to give heparin to this patient.
Sir, I'm with heparin. I'm with heparin.
Wonderful, brilliant. Third answer is heparin. Brilliant. Third answer is heparin. Okay, fine. So now let me discuss with you first, Dr. Rabia. Why you want to give the heparin to the patient?
Because the
Can you give the
scenario,
diagnosis of this patient?
fat,
Diagnosis of
fat,
this patient.
this is the scenario of fat embolism, and
Fat embolism.
patient ABGs are quite disturbed. We have to resolve the embolism first. So give the heparin.
Okay. So this is a fat embolism. I can say this is not a fat embolism. This is something pulmonary embolism.
Pulmonary embolism.
How you diagnose that? Without diagnosis, would you like to give some treatment to the patient? Because diagnosis is not there. How can you jump to the diagnosis? I mean, treatment without diagnosis? It's a discussion. Huh? You can answer me.
Yeah, sir, because of
This
the
is how we
fracture,
treat in the patient. Huh? This is how we treat in the clinic. Nah? Yeah.
post fracture of the hip, patient develops short of breath.
Okay, fine.
Sir,
It
So
is
shortness of
post
breath will
embolism.
confirm.
And
Sorry.
ECG shows sinus trachy. It could be pulmonary embolism or could be fat embolism. The common scenario is
Fair enough. Fair enough. So that is what I'm asking. So it could be. It could be. So you don't want to diagnose first, then what is the emergency in this patient to treat first without diagnosis?
there is no
What
emergency.
there is
Just
no emergency,
AB.
right? Fine.
Yeah,
So when there is a no emergency, why we are not going for the investigation?
that's
Like
good.
patient has acute chest pain. Is it good idea to give directly the thrombolytic without ECGs or something else or trop T, trop I? Is it good idea? Okay, fine. You have chest pain. It's a classical looks like I don't need ECG. Go and directly give thrombolytic. What do you do in your practice?
So if I have availability of investigation, then definitely go for CT angiogram. If not available, then
No,
treat.
it is available. No, it is not mentioned in the scenario that it is not available. What they are
Then
Here
asking
is
is, what they are
chest
asking
X-ray is
here is a
normal.
the next best. So what you can do the next best among the all list? What is the next best by your
So
experience?
according to case
Section A.
presentations,
CT angiogram.
Okay. Another
sir, here
answer
is
is
chest
CT
X-ray
angiogram.
is normal, so we can go for VQ scan.
Okay. So now what is the sensitivity and specificity of VQ
CT
scan?
angiogram
And
is
what is
more
the
specific and sensitive
sensitivity
than
and
VQ scans.
specificity of VQ scan? Yes, tell me.
It's about 70 to 80%.
CT
Which
angiogram
70
is
to
more
80% of
sensitive and
what?
specific, sir.
VQ scan or this scan? Which
VQ
scan
scan.
has 70 to 80%? Okay. And what is the sensitivity and specificity of angio, CT angio?
90 to
Oh,
95%.
so
90 to 95%. So, Piyush sir, which would you think it is better? The test which is 70 to 80% sensitivity is better, or 90 to 95% sensitivity is better?
sir, here CT angio is based for suspected pulmonary embolism, but chest X-ray is normal, so we can go next.
Just like,
Best investigation is VQ scan.
The patient
right.
is stable,
So,
so we go
this is
option
homework
A.
for everyone. This is homework for everyone. Suspected pulmonary embolism and chest X-ray is normal. Which would be the next most important test to do? Do some research. Do some research that will improve the knowledge. Do some research. Chest X-ray in initial pulmonary embolism is normal because I did highest chest scan because pulmonary embolism is everyday's problem in our things. When patient has a cancer, right? They have, I mean, cancer is among one of the biggest risk factor for thromboembolism, especially venous thromboembolism, right? So we do a lot of X-rays and the CT angios and all ask for this, right? So what do you think? Any other comments from the audience? What would be the best for this? This is very important, very common in day-to-day practice. Everybody
CT
will get the
angiogram.
problem like this. CT angiogram. Fair enough. Let's
Best is
see
no
how
doubt CT
will
angio, sir.
wonderful. So let's see little literature probably, right? So what is the clue? So this is history, right? Everybody will remember the history, right? So this is history. Now I'm dissecting the question. Key clues in the question. What is the clue in this question is recent hip surgery. This is one, right? This is one thing, right? And which is a strong risk factor for venous thromboembolism. There are a lot of risk factor for venous thromboembolism, VTE or thromboembolism. One of them is a recent risk factor, right? Another important thing is a prolonged immobilization because of anything, maybe stroke or spinal fracture, prolonged immobilization. Third thing is a cancer. Cancer or cancer cell releases a substance or chemicals which makes the blood thrombotic. So cancer is a risk factor. Fourth is a thrombophobia. So DVT will not happen in a normal, otherwise fine individual like you and me. We never have developed any DVT. These are the risk factor. So if you have any of the risk factor, think of DVT. What is the consequences because of this venous thromboembolism, especially in a pulmonary vessel? In deep vein thrombosis alone, you won't develop the breathlessness. Na? They have pain, they have swelling, they have tenderness in the calf because of calf DVT. That's it. But they don't have breathlessness. Patient has the acute shortness of breath, means some kind of thinking of pulmonary embolism. There are three ECG changes. Three ECG changes. This is again examine question. Three ECG changes. If they ask you which one is the most commonest ECG changes in pulmonary embolism, then tachycardia, right? Second thing, which is non-specific ECG changes, then ST and T inversion. Second,
Most
then
event
which is the most diagnostic and pathognomonic of
pathognomic is
pulmonary S1, Q3,
acute treatment.
Q3.
Q3.
In lead 1 S wave, in lead 3 Q wave, and lead 3 T wave. If you see, it is none other than pulmonary embolism. Three different question in exam. Most common answer is tachycardia. Most non-specific is this. Most diagnostic pathognomonic is this. Tachycardia is not most diagnostic. This is most. So what they exactly ask, you have to answer accordingly. Wonderful. So we solved three questions here as well. Chest X-ray is normal. ABG, respiratory alkalosis. Our patient has a respiratory pH is 7.48. PCO2 is low and mild hypoxia. This pattern classically confirms the pulmonary embolism, right? So this is like strong evidence of pulmonary embolism. So we reached up to the diagnosis that okay, this is likely pulmonary embolism. Now, what is the base next step in this patient? Next best step in patient. Any management comes. Forget about pulmonary embolism. This is how it works medically. Ask yourself first patient stable or unstable. It applies to any condition, believe me. It applies to any condition. You name the disease, it applies. Right? Hemorrhagic shock. Patient is stable or unstable? Management change. Acute myocardial infarction. Patient is stable or unstable? Patient. Ventricular tachycardia. Patient stable, unstable? Management change. VT stable, I will give palm. Procainamide, amiodarone, lidocaine, Maxal. If patient is not stable, I will give DPAP. That's it. Answer change. Patient stable versus unstable. So this patient is hemodynamically stable. How do we get to know? Again, somebody asking me, sir, what is the definition of unstable patient? Right? So unstable patient is definition. Fix in your head. Anything less than systolic blood pressure is less than 90 is unstable. Any patient is unconscious is unstable. Is that clear to everyone? Yes or no? Yes or no?
Clear.
Yes, sir. It's
Is
clear.
stable. Our patient is not less than 90 BP. Our patient is conscious, well oriented, fully, right? So our patient is not unstable. So our patient is a stable. So go back to this scenario, right? Our patient not less than 80, 90 blood pressure, right? So our patient is absolutely normal blood pressure, less than 90 systolic is unstable, right? Patient is absolutely fine. There is no mention, right? And our patient is not unconscious, is fine, absolutely fine. So first emergency is to diagnose patient, especially stable patient. If this patient is unstable, then treatment, jump on the treatment, jump on the treatment. So what is the final answer for this? Because the patient is hemodynamically stable, right? First, next step is to confirm by imaging study, and best imaging study is CT angiogram, specifically CT pulmonary angiogram, which is the first line test for suspected PE in stable patient, not unstable patient. Is that clear to everyone? Yes or no?
Yes. Yes, sir.
Yes, sir.
Uh,
Yes.
Can anyone tell me? Can anyone tell me contraindication of pulmonary CT pulmonary angiogram where you not supposed to do?
Pregnancy,
Contraindication. Contraindication. One is pregnancy.
And
Wonderful,
renal
brilliant,
failure.
super brilliant.
allergies,
Second is a,
contract,
renal
contrast
Renal
means.
failure.
failure. Renal failure, yes.
Why renal failure? Because you need to give dye. Contrast you have to give in the vein, and contrast will further damage the kidney. So pregnancy and renal failure is contraindication of pulmonary angiogram. Is that
Also,
clear? So this is again, sorry,
so if a person is allergic to dye,
wonderful. And third is allergic to dye. Wonderful, brilliant. So we'll cover that. So why not other options? We have five options. Why not other options, right? So apixaban treat, right? It's a treatment, but diagnosis should be confirmed first in stable patient. So in context with that, apixaban is not a good answer at this point of time. Why not VQ scan used when CT angiogram is contraindicated, Piyush sir,
Okay, sir.
right? So CT angiogram until proved otherwise is number one, carries high sensitivity and specificity, right? So when CT angiogram is contraindicated condition, I already told you, and somebody told pregnancy, renal failure, allergy. All super brilliant answer received from the audience. So in this three condition where you supposed to not perform this CT angiogram, in that case you go for the VQ scan. Is that clear to you, sir?
yes.
Wonderful. D dimer, it is like low clinical suspicions, right? It's not much important. There are lots of false positive D dimer. It will not diagnose the things. Lower extremities supportive, but not the first line to diagnose PE. Whether deep vein thrombosis, whether there is in the calf, right? Whether in the calf clot is there or not, you need to do a pulmonary angiogram, right? Because this will give you the suspicious, right? It is a supportive evidence, but not the confirmative evidence of DVT. Whether DVT is there or not, you have to treat this patient. It's symptomatic patient. Intravenous heparin start immediately only if unstable. So here the answer will change. So when the what is a pulmonary embolism? Stable patient, diagnose first, pulmonary angiogram, and then treatment. Patient is unstable, patient is in absolutely shock. You don't need to be a hero. First treat, then diagnose. Is that clear to everyone? Yes or no?
Yes.
Any doubt?
No, sir.
Sir, I
Any
have a
comment
doubt,
on?
sir.
Yes, please. Ask the doubt.
Yes, sir. Sir, if we diagnose that it is pulmonary embolism, and we have to go for chest X-ray, and if chest X-ray is normal, in some other books I have seen that if chest X-ray is normal, we have to go for VQ scan. If chest X-ray is
Yeah,
abnormal, then we have to go for CT
and
angiogram,
CT
etc.
angiogram.
So yeah, fair
Uh,
enough. Fair enough. So that you post that literature you post it in the group, right?
yes,
Here
sir.
they are
Yes.
asking the
So
next best. So
Okay.
VQs can go and read it. Go and read it. Do some
Okay.
homework as well. It will improve your knowledge. So VQ scan versus pulmonary angiogram. Read only one thing. Was it is a sensitivity and specificity? What is the sensitivity and specificity? Who has a better sensitivity and specificity? That is number one test. Not for this, for any test,
Okay.
right?
Okay.
So, by my knowledge, the pulmonary angiogram has absolutely high sensitivity and specificity compared with VQ scan, and it is time consuming as well. There are less expert as well. Everywhere it is not available as well. These all are the limitation of VQ scan. VQ scan is basically used in pregnant women where you are avoiding and renal failure. Are you getting me? Yes or no?
Yes, sir. Okay.
But you go and read, and we have a group. You can post some authentic evidence based information on this. So if something is contradictory, we will change. But as of now, pulmonary embolism or pulmonary angiogram is the answer for
Sir,
this.
sir,
Okay,
one
sir.
question, sir.
Now again, yeah, so last slide for this of pulmonary embolism. If you remember this only one slide, all the queries will be solved. Stable patient, next step is CT pulmonary angiogram. Stable patient, right? What happens? Unstable patients immediately give anticoagulation like heparin. Patient has a pregnancy and contrast. CT pulmonary angiogram is contraindicated. That is why you are going for VQ scan, right? And D dimer is not much important here now. So that's it. This is like very short table which explains everything. Any
Sir, one
confusion?
question, sir. Yes, sir.
Yes, please
Sir,
ask me.
if there is a classical history in this case, so why we want to confirm
We want to
this is
confirm because patient is a stable, and there is no emergency. So in our clinic or practice, in general practice globally, right? You are also seeing a lot of patients. So when patient has a fever with rigors, right? So we try to differentiate, especially in India. Okay, fine. Let's check for the malarial parasite. Will not empirically start. If you have classical history of tuberculosis, patient is stable, we'll try to confirm by sputum, by X-ray or bronchoscopy. We confirm the diagnosis and then jump treatment. So overall idea is that when patient is stable, treatment is not very urgent, right? Try
uh,
to
but, uh,
confirm the diagnosis, not the probable diagnosis. Confirm because patient is stable, na? Abdominal pain, renal colic, right? You just confirm it, na? Confirm and like do some simple X-ray or USG. Confirm, give it because you are thinking renal colic, but it could be, I mean, probably mesenteric ischemia. It's a bowel obstructions. It's something else, right? So without diagnosis, you may sometime go in trouble. This rule applicable only in non-urgent patient.
but this case is confirmed everything in history, everything. So directly
Okay.
can jump to treatment.
If you do not have anything, by my sense, by my experience, if you have no VQ scan, if you have no pulmonary angiogram, right? In that case, what you can do? Let's discuss that as well. If you do not have in your hospital, CT pulmonary angiogram is not available. You do not have VQ scan, right? What you do? You can do ECG. ECG, what I told you, increase heart rate, right? Patient has high risk post fracture, right? You do D dimer. You do D dimer. If D dimer is very, very high with high suspicious, in that case, you can go for treatment without doing this or this. But if you have this, better you do this. Are you getting me?
Yes, sir.
Wonderful. Any question? Is all clear? Those who answered heparin or VQ?
Yes, sir.
Wonderful. Let me jump to the one questions of this spot diagnosis. Spot diagnosis. Nothing. Short, very short questions. You have a patient of, say, for example, 50 years male presented to you with some weakness and difficulty in breathing on long walk. CBC was done. Hemoglobin was 7. Total count is 80,000 per cubic millimeter. Platelet is 30,000 per cubic millimeter. No options of the condition. What is the diagnosis? What is the treatment? Peripheral smear is in front of you. So this is a CBC or complete blood count. I had given you complete blood count. Right. So this is a CBC of the patient. This is a CBC contains three things, right, of the patient, and this is peripheral smear review. Right. We have a slide, right? We make a tongue shaped peripheral smear, right? And this peripheral smear under microscope looks like this.
Sickle cell.
Yeah, you can answer what you can see here. What is a platelet? Whether you see the platelet or RBC or WBC or what's the problem?
Pancytopenia, peripheral smear showing
Wonderful.
myeloblast,
This is pancytopenia. Brilliant.
peripheral smear
Very well.
showing
Yes, this is
myeloblast.
my. So pancytopenia means low HB. Yes, it is low. It's supposed to be 13 in male. It is 4,000 to, not pancytopenia, high count, sir, sorry. Leukocytosis with bicytopenia, not pancytopenia. WBC is high, sir, na? Pure, sir. Normally, it's supposed to be 4,000 to 11,000. It is 80,000. So hemoglobin
Sorry.
is low, WBC is high, and platelet is low. It is not 30,000. It is 150,000 to 450,000. That is normal range. You must know it, right? So low HB, low platelet count, high WBC. What could be the differential diagnosis here? What could be the differential diagnosis here from the audience?
Leukemia.
Random leukemia. Okay, fine. Leukemia. Okay, fine. Not bad. Leukemia.
Leukemoid reaction.
Leukemia. One is leukemoid reaction. Wonderful. Very brilliant answer. Leukemoid reactions. We'll differentiate why leukemia or why leukemia, why not leukemia. Because you have to don't forget this triad, gentlemen. Diagnosis, investigation, treatment. So diagnosis, we need to make some diagnosis or differential. So we have two differential diagnoses. One is leukemia, another is leukemoid reaction. So yes, Piyush sir, tell me what is the difference between leukemia and leukemoid reaction?
Leukemia in peripheral smear, we can see blood cell.
Leukemoid reaction and leukemia. Let's discuss leukemia. Okay, fine. It is all question. They may ask you leukemoid reaction questions as well. So we need to know each and everything. Yes. Anyone open for all? Anyone wants to comment on leukemia versus leukemoid reaction?
Leukemia reaction is caused by some infection, stress, or inflammation,
Okay, so leukemia reaction is either infections or inflammations in leukemia reactions. Okay, or some kind
and
of
that
stress in the body.
yes, and
Okay, fine.
leukemia is carcinoma. CA,
Sorry, leukemia is what?
CA, like it's
Blood
a cancer.
cancer.
No, but how do you get to know this is leukemia or leukemia? So here you told me the mechanism, if I'm not wrong. If you have
Yes,
infections or inflammation or stress, you may develop the leukemia reaction. So what makes the leukemia to happen? Here the infection can cause leukemia reaction. So what can cause leukemia? So leukemia is basically stem cell disorder, right? There could be a
okay,
biological, age, genetic, viral, or any kind of mutations or carcinogens can disturb the stem cell and that develop the leukemia. Fine. So let me tell you, this is the one story. Second is leukemia reaction. Leukemia reaction usually WBC count are between 50,000 or usually less than 50,000. Here usually more than 50,000. Usually here no blast, no blast. Here blast cells are present. In leukemia reaction, only WBC will increase. Usually here hemoglobin and platelet are usually normal. Here, all three abnormal. WBC abnormal, hemoglobin abnormal. So, all three abnormal means something wrong with the bone marrow, not just the infection. So, this is again right here. Here normal. Here in leukemia, usually there is no hepatosplenomegaly, right? Here you can see hepatosplenomegaly. Are you getting me? Yes or no? Yes or
yes,
no?
sir. Yes, sir.
Right. So, these are the few differential points for leukemia reactions to leukemia. So now what do you think? Is it leukemia reaction or leukemia?
Leukemia.
Leukemia. So let's dissect this question. First question, we reach to the some provisional diagnosis. This is leukemia. Second questions, right? Acute leukemia or chronic leukemia? Second question.
Chronic.
Acute.
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 Wonderful. More question. Acute myeloid leukemia or acute lymphoid leukemia?
Myeloid.
Myeloid leukemia.
Wonderful. Acute myeloid leukemia. Acute myeloid leukemia has 8 subtype, M0 to M subtype. Which subtype of this leukemia? Lots of question I'm asking you, right?
Okay.
It's a learning. Which subtype? This slide
M2.
will tell you everything. We
M2
see
is
when we
communist.
started. Sorry,
M2 is communist, sir.
which one, sir?
Yes. M2, M2.
M2. But this slide, I mean AML, and this slide, which is M0 to M7. What you comment? M2 you want to comment?
Oral rods are present in there is
Sorry,
line
Yes, just
cytoplasm function. Oral rods are present. So
Yeah, all
M3,
rods are present.
M3, sir.
3. Okay, M3. What is M3, Doctor Anisha? What is M3? This all are exam question, huh? Because people are confused between acute chronic, myeloid lymphoid, AML, subtype, M3. What is M3? Tell me three
Promyelocytic.
important things about
acute
M3.
pyromyeloid. Acute
Promyelocytic.
pyromyeloid 2.
Acute
Pyromyelotic.
promyelotic leukemia.
Tell me the three most important three things about M3. Most three important high yield point for the
Prognosis, sir. Good
PIC
prognosis.
is
okay, one is
common.
a prognosis. Let me go one by one. So prognosis is good or bad
Good,
or
sir.
worst?
Good, good.
Good.
Good. Wonderful. Let me put the word best. Amongst M0 to M7, 8 subtype, M3 has a best prognosis. Best means 80% patients will cure forever if you treat well on time to them. We have lots of acute promyelocytic leukemia or M3. M3 is known as acute promyelocytic leukemia as per the WHO classification. Another name of M3 is acute promyelocytic leukemia. So prognosis is best. 80% plus patient will cure forever. They are leukemia free. They are enjoying their life. Best This is one point. What another point for acute promyelocytic leukemia?
Treatment with chemotherapy, uh, all trans-retinoic acid is given, sir.
Atra,
Wonderful, brilliant. So ATRA plus arsenic trioxide,
arsenic
ATO.
trioxide,
Arsenic trioxide plus ATRA is a drug of choice. Second, very important
DIC.
point because,
DIC is
right,
common.
wonderful, brilliant, brilliant. So most common presentation of APLC is DIC, right? So these are the absolute high. Rest of the things are same. Patient has fever, patient has bleeding, patient has lymphadenopathy, bone pain, weight loss, blah, 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 whatever you tell, all same in M0 to M7. These are the specific points which we need to remember. We should not afford to miss these points in for the sake of the exam, right? So now this is what this is called as. You can see some kind of rod kind of things in the cytoplasm. So now
Or
let me draw the
roach.
normal cell. This is normal cell, right? This is normal cell. This is one rod in the cytoplasm, what we can see here. So one here, the same another cell, here the one OR rod. If there is a multiple OR rod, then what to do?
Very good.
This is multiple. Can you see the multiple? So this is called OR rod, AUER OR rod. And when there is a multiple OR rod, it is known as a faggot, FAGOTT, right? Like like it's a bundle of sticks, right? It's a bundle of sticks. It's a bundle of stick, multiple OR rod. Now you can see this picture very clearly. Brilliant slide. Can you see? Do you recognize multiple or not? Yes or no? At least tell me yes or no.
Yes, sir.
Yes, sir.
Right. So bundle of OR rods, it's called as a faggot. And faggot is the diagnostic of M3. So by seeing one slide only, forget about this complete. Forget about this. If somebody can give me this slide without any zero history, I can see in 1 second, okay, sir, this is AML M3. That's all, khalas, done. Is that clear to everyone? Yes or no? Yes or no?
Yes, sir.
Yes, sir.
Yes, sir. Yes, sir.
Wonderful. Wonderful. So now, what is the diagnosis? So diagnosis is AML, acute myeloid leukemia, or rods is equal to AML. I told hundreds times in my every lecture. Or rod is equal to AML, and AML is equal to or rod is equal to AML, AML is equal to or rod is equal to AML. It is not seen in CML, not seen in CLL, and not seen in ALL. So it is not seen in CML, CLL, AML, ALL. Only and only seen in AML. That's it. So if you have OR rods, you don't need to confuse whether it is acute lymphoid leukemia, chronic myeloid, or chronic lymphoid. It is none other than AML. So we have very clear cut OR rods here. So what is the diagnosis? AML. Even you have pancytopenia, no pancytopenia, nothing. Forget about this. Even they don't give you the CBC, only this picture spot diagnosis, AML M3. That's it. Is that clear to everyone?
Doctor, what do you mean under the word aurora?
Sorry, sir.
You said depending looking at this aurora, so we can clarify that's AML. Aurora.
Yes, sir. That's correct. Yes, sir.
What do you mean exactly? What is aurora?
Or rod is
I'm not.
basically, yeah, I'll tell you, sir. It's a good question. It's a simple normal cell or white blood cell, right? There is a no cytoplasmic inclusion or rod-like structure in the cytoplasm. This is nucleus, this is nucleolus, and this is all cytoplasm, right? So in cytoplasm, when there is a rod-like structure, it is called as a or rod, AUER or rod, which is not there in a normal cell. And when there is a bundle of OR rods or multiple OR rods, it is called as a faggot.
Thank
Are
you.
you getting me, sir?
Huh.
Did you get the answer, sir, or not?
Yes, it's clear. Thank you.
Wonderful. So whenever you see the peripheral smear, look at the rod-like structure in the cytoplasm while you are answering in the exam. So if you just keep these tips in mind, within 1 minute, 10 seconds, you are done. You don't even, they had given you very long scenario, 10 lines, 20 lines, forget about everything. Or what is in AML. That's it. And if they ask which AML, M3, that's it. Brilliant. So faggots are seen in acute promyelocytic leukemia. Probably will, this is the last question, so bear with me. Faggots are seen in acute, what is a faggot? Multiple or rod is a faggot, right?
Multiple.
So acute promyelocytic
Forwards.
leukemia, right, characterized by promyelocyte containing bundle of or rods. Or rods is equal to AML. It is needle-shaped granules in the cytoplasm, multiple or rods in bundle called faggots, and it is strong association with translocation of 15 and 17. This is important gene. This is called as a PML-RAR alpha. PML-RAR alpha, which we need to detect by FISH test in this patient, and high risk for DIC. We already seen everything in our things, right? So high risk for DIC, disseminated intravascular. So I've seen few patients in my hospital, patient coming with a bleeding, they have low platelet, they are bleeding, blah, 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 blah. And somebody saying, sir, this is DIC. Somebody saying, sir, this is some kind of septicemic shock followed by DIC. Patient has fever, bleeding. What my job being hematologist, check the CBC, look at the peripheral smear. They have long list of differential from ICU team, from infectious disease team, from various expert. But my job is 5 minutes, sir. Nothing is there. This is AML M3 or rod is seen. It is AML. Problem is solved, right? So we treat AML. We give antibiotic. We give platelet transfusion, right? But we do the diagnosis, right? So we need to do the diagnosis. So any patients now onwards comes to you or presents to you in your emergency room with DIC with abnormal CBC, DIC with abnormal CBC, must look for the OR rods in the plasma. Is that clear to everyone?
Yes, sir.
Yes or no?
It's clear.
So abnormal, so this is for APL, acute promyelocytic leukemia is equal to M3. The name of the M3, there are classification as I told you, M0 to M7, right? M0 to M7. M3 is known as acute promyelocytic leukemia. Abnormal, the name itself, promyelocytic leukemia means promyelocyte. Promyelocyte develop the myelocyte. Myelocyte become a metamyelocyte. Metamyelocyte become a band cell, and band cell become a neutrophil. This is what the evolution of the cell from the stem cell, right? So I'm not going much in detail of evolution of things just to make things easy. This is acute promyelocytic leukemia or rods, multiple faggots, term faggot, genetically translocation 1517, treatment atra, all trans retinoic acid. It is the derivatives of vitamin A, vitamin A. And what is the job of this atra? The job of the atra is to make this all immature cell to mature cell. This is the one of the biggest function which makes them faster, immature. So acute leukemia, mainly you see immature cells, right? And arsenic or arsenic trioxide is a chemotherapy. So it's a combination of drug, and the complication or presentation is the DIC in APML or acute promyelocytic leukemia. So it's a very important things. So our scenario was HB was 7, WBC was 80,000, platelet was 30,000, peripheral smear promyelocyte with multiple or rod called as faggot, acute promyelocytic leukemia AML M3, and association with this translocation 15 and 17, and that's it. So treatment is what? Immediately you give atra, add arsenic trioxide, high risk patient, add anthracycline. DIC management you can do with the bleeding. So if platelets are low, you give platelet. If the factors are low, you give FFP, and if the cryoprecipitate mainly for the this fibrinogen. Cryoprecipitators are rich in two things. Cryoprecipitators are rich in two things. One is 1 Willebrand factor, good source is cryo, and factor 8. When you, right, so DIC is every problem. DIC platelet is also problem, factor is also problem, right? So you need to give the complete product as per the patient's clinical profile, right? And one of the important thing is you should delay in the right, avoid delay in the ATRA. So you should not delay. If you suspect, okay, this is AML or rods or faggot in cytoplasm, and start immediately, even before confirmation. So somebody is saying, oh, sir, I want to do flow cytometry, I want to do bone marrow, blah, blah, blah. You do it. Don't worry, you do it. But start ATRA. That prevents the complication and DIC complication. So APL, acute promyelocytic cause severe DIC, most common cause of death and bleeding from the because of low platelet and factor. There is a fatal bleeding, and that is the commonest intracranial. And because of that, patient may die. You don't want to die the patient due to DIC and bleeding. Give the give the drug called as a ATRA. That's it. That's it. So what is the take-home message? Diagnosis, acute promyelocytic leukemia, treat, start ATRA immediately, and arsenic trioxide. Prognosis is the best. If you give the proper dose combination to this such patients, then it is like almost 90% cure for this patient. That's all. Would you like to discuss one more questions, or I pack up? Depends
One
on
more.
you.
Yes,
Sir,
sir.
one more, please. One
Can do
more,
one
please.
more
Energy.
question.
Wonderful.
Yes.
Your energy level. I have tremendous energy. Wonderful. Last questions for today. Forget leukemia now, come to the different box of the things. It's all hematology, but very common what we see in our practice. 58-year-old man with history of rheumatoid arthritis, present with fatigue, HB is 9.5, MCV is 82, serum iron is low, TIBC is low, ferritin is high, CRP is high. What is the most likely diagnosis is? Iron deficiency anemia, anemia of chronic disease, is it thalassemia, is it sideroblastic anemia? Take your time. It's a very important.
Anemia, chronic disease.
Okay, so one answer is anemia of chronic disease. Let's see what other.
Of chronic disease.
I agree. It's anemia of chronic disease.
Why not iron deficiency?
Maybe
Serum
it will be high.
MCV
TI,
with total iron
TIBC.
Because of
value,
creatinine, in iron deficiency, creatinine should be low.
Fair enough. That is also again very important point. So simple one
And
line if I want to tell anyone iron deficiency anemia when you are dealing with, right? So iron deficiency
मैं
anemia
क्लास होने के बाद में लेके आती हूँ
low ferritin,
हाँ
low ferritin.
नहीं 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 वो थोड़ा क्लास
Sorry, I muted you, Indu. So iron deficiency anemia low ferritin and anemia of chronic disease high ferritin. If you remember one word, your job is solved. Only one word. Here ferritin high. So forget about the iron deficiency. Simple one word. Low ferritin, iron deficiency. High ferritin, forget about iron deficiency. Forget about the iron deficiency. And after the most common thing is anemia of chronic disease. So in that context, right? So here you can see all things chronic, right? The how the name evolves. What do you mean by sir anemia of chronic disease? How is this diagnosis? How is the name of the diagnosis? That is how the word anemia of chronic disease. The name itself suggests because of chronic disease, people are developing the anemia. So what are the chronic disease? Now we need to know, sir, what are the chronic disease? Can you tell me the list of chronic disease? One is a rheumatoid arthritis.
Rheumatoid arthritis.
Right. Second is a
Creatinine.
chronic renal failure.
Renal failure.
Chronic renal
Crohn's
failure.
disease. Hmm.
Crohn's disease. Another is chronic liver disease or alcoholic or chronic liver disease. Chronic hypothyroidism. So
Result.
all chronic disease eventually because of interferon and interleukins and all various mechanism, right? They develop the anemia. Iron deficiency is not there. Iron is rather, let me tell you, iron is enough iron in a anemia of chronic disease, enough iron. But unfortunately, this iron is not used to form a hemoglobin. So it's not a quantitative problem, it's a qualitative problem, I can say. Uh, right? So iron is there, but hemoglobin is not getting formed, and that is why hemoglobin is 9.5. So even at 58, I told you the three numbers, if you probably not forgotten, he is a man. So man less than 13 is anemia, right? Female pregnant, right, less than 11, and non-pregnant 12. So 11, 12, 13. Is that clear to everyone? Yes or no? Right.
Yes, sir.
So this is likely iron anemia of chronic disease. Even you don't go with this any numbers and all complicated things, right? The name itself suggests, right? So this is anemia of chronic disease. Let's dissect. Anemia of chronic disease, low iron. So this is anemia of chronic disease. What exactly you see in the anemia of chronic disease, right? So in anemia of chronic disease, iron could be low, right? Ferritin is absolutely high, and this is the difference. Low ferritin and deficiency. High ferritin, anemia of chronic disease. Our patient has high ferritin, right? So this is classically things. So only one thing you remember is more than enough. If you remember even this, right? Whenever you are answering anemia of chronic disease or iron deficiency, look at the ferritin. Number one, right? Look at the ferritin. Somebody is asking, sir, what if it is ferritin is given as a low, not high, but it could be a no, normal sometime, right? Then look at the second parameter is TIBC, total ion binding capacity. Look at the TIBC, total ion binding capacity, TIBC. Got it? TIBC. So what is TIBC? In iron deficiency, it is low. Anemia of chronic disease low, iron deficiency high. Two parameters, which is absolutely right. Ferritin in iron deficiency is low, here high. So these two parameters which completely right give you diagnosis. This is IDA, iron deficiency anemia, right? Iron deficiency anemia, ferritin low, here ferritin high. Here TIBC high, here TIBC low. That's it. These 2 points, they will not confuse you in exam. They will give you clear cut idea about exam. But we are so in hurry, we do the mistake. So I don't want you to do the mistake. And this is the head-to-head comparison. Iron can be low in both the things. Here you see the differentiating iron deficiency, TIBC high, TIBC low. Ferritin iron deficiency low, here high. That's it. If you remember this, it's more than enough. That's it. So that's all from my side. Thank you very much all for listening me coolly and calmly for 1 hour and 43 minutes. I hope you enjoyed this all session. And before the last slide, we got lots of calls I'm getting every day and messages, sir, do something to reduce the subscription cost. So I had given open global challenge. If anybody get better than this package in the world, you get 100% money back guarantee, not 99%, 100% money back guarantee, right? In which you use whole the website, unlimited, whole the website for 1 month, unlimited. Book, website, coaching, subscription, mobile application, mock test, recall, whatever you want to use, all 100% free. Only condition is you need to found and do some Google research who is offering this package globally, not in Middle East, globally. Coaching is there, which cost you around $300. Hard copy book in India cost you 50. Ebook cost you 25. Everything is there on the website, so you can go and cross check it. 1 month subscription 50, video library, WhatsApp subscription, crash course or mock test. It is altogether 625, which is now delivered from 1st of the April in just 100. That's it. So your job is to find out something better than this. It is free. Probably you have hard time to find. So a lot of people are telling and asking me, sir, financial problem, this and that. So I'm just like, this company is not started for the financial background or to earn the money, and that is why we are doing relentlessly. Nobody can, I mean, argue with me that we are not sincere enough, more than sincere enough. And I'm doing absolutely free session every Sunday on right? I mean, with the full energy for last many years. Every Sunday, 11 to 1 or 1 to 3. You just need to keep watch on the time. So that's all. Thank you very much for your kind attention. And those who are interested, just nominate their name to the Pallavi. Probably this is absolutely for limited offer, believe me, because we are getting a lot of calls. So just to have a solution for this is Pallavi, our support manager, and this is me, myself, Dr. Munjal. So I would be glad to guide you all guys. And that's all. Before I end up my session, I would like to have very quick feedback. How did you enjoy it and clarify your concept from the today's session? Just a quick feedback here. I think if you are not in hurry, just spend 2 more minutes.
Sir, excellent, as always.
Wonderful, brilliant. So I would like to ask you one more question. What did you learn more?
Actually, sir, in the beginning, you taught us about the AML and certain the leukemias, but unfortunately, I forgot about it. Today it was a big revision, and I I was worried that how am I going to revise that? So you did it, and it was wonderful.
Wonderful. So we have exclusive another leukemia class on our YouTube channel. Hematology. I have many lectures on the YouTube, the channel. You subscribe it, so you get all updates. And you go back. I have written clear cut that hematology class, this class, that class. So just look into it, right? So
Yes, sir, I
you
am.
get
I am
the
going through your channel right now.
sorry, ma'am.
To I'm channel going through your channel right now.
Wonderful. Wonderful. No
So
problem. No problem. You can look for the hematology. Yes, wonderful. Anybody else wants to have any quick comment, Dr. Shahrukh?
Thank you very much, Dr. Munjal. It was so interesting, as usual, and very helpful, I think, for all who are preparing for PROMETRIC. Thank you.
Wonderful. Any other comments who joined the first time? I don't know. There are a lot of doctors. Sorry. Zahabia, your comment. Did you learn something, Dr. Zahabia? You looks like a new client.
Yes. Thank you so much, sir, for the class. It was amazing. Personally, I'm someone who gets really confused with hematology and leukemia and these big terms. But when I studied today, it made some sense to me, and I'm really, really grateful for it. Like, you actually sparked an interest in me when it comes to the subject. So that was the changing point for me. And thank you
Wonderful.
so much for
Brilliant.
that.
You are
Yes.
welcome. Which exam you are
Mm.
preparing for?
I'm preparing for DHA.
Wonderful. When you
Yes.
supposed to give your exam?
In upcoming few days. I have still yet
Upcoming.
to book a date.
Fair enough.
But I'm trying to prepare, and then once I book the date, I'll let you know.
Keep in touch. Keep in touch. Do let me know for any further guidance or assistance. I would be
Sure,
glad.
sir. Sure. Definitely. Definitely.
Thank you very much. Yes, sir. Yes, sir. Anyone else?
Very good session, sir. You just made us revise and pick up the important points. Very interesting, sir, as usual. We never get bored, sir.
Thank you. Yes. Yes. Anyone? Last but not the least. Yes. Dr.
Excellent, sir.
Mariam.
Dr. Purani, Rajesh Purani.
Yes, sir. Dr. Rajesh Purani is my batchmate and he is close friend of mine. So thank you very much, sir, for being in the class. Throughout your
Thank you,
class,
sir.
we learned a lot of from you. So thank you for your presence
Attended
in the
very
class.
first time, but it's my promise I will try to attend as much as possible. Very amazing, sir.
You learned something, sir, right? If I'm not wrong.
Yes, 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 yes. Sure, sure.
Thank you very much, sir.
Thank you,
Yes,
thank you.
Saranya, Piyush.
Yes, sir. Yes, sir. It was an excellent class, sir. I couldn't attend from the start, sir, due to my situations, but I have joined in between, sir. It was an excellent class, and I got to keep up with my notes, sir.
Wonderful, brilliant, brilliant, Saranya. You are a
Yes,
brilliant
sir.
girl, I know. Wonderful. Thank you very much. Yes, Nisha Ramakrishnan. Okay, fine. So I think all pack up for today. Thank you very much for your kind attentions. Keep in touch, and we'll see you soon with the next class with interesting topics and questions. But do revise. And for any hematologic queries, feel free to directly message me. I'll try my level best to catch you as soon as possible. Thank you very much and enjoy your Sunday. Thank you.
Yes, sir.
Thank
Thank you
you.
so much, sir.
Thank
Yes,
you
thank
Drop
very
you,
little
much,
sir.
Doctor.
feedback in the group as well whenever you get chance and time in the group. Thank you.
Okay, okay. Thank you, sir.
Take care.
Thank you so much, sir. Thank you.
Thank you very much. Thank you.